So it's really great to have all these great conversations going. And there will be many more times. Anna asked me to remind everyone, which I'll remind you again after the next time, that you are all welcome to the alumni reception, which will be following the last talk, and it will be across the street. You just have to go out the front door, go across the street, up the steps, go in, and it will be in the community room. So I hope you all join us at least for a little bit. And introducing our next speaker is Jess Millett.
Hello, I'm introducing Justin Cohen. Justin got his BA in molecular, cellular, and developmental biology at Yale before coming to University of Michigan Public Health in 2002, where he first got an MPH in what at the time was called International Health. I'm assuming that's now the Global Health Program. And then he continued on into a PhD in epidemiological science with Mark Wilson studying malaria in the Kenyan highlands. In 2007, he joined the Clinton Health Access Initiative, first as a senior tech advisor for 6 years, and then for the last 5 years has been the senior director of the Global Malaria Program, which provides operational support to over 20 different government malarial programs to increase funding for malaria, expand access to quality diagnosis and effective treatment, and to optimize the impact of national malaria elimination programs. Please join me in welcoming Justin Cohen.
Thanks very much, Jess. Jess also caught that I had my MPH year incorrectly on my first slide, so I appreciate the attention to detail here in Michigan. So now that you know all my personal secrets, I'll jump straight to honoring Mark here. This is me looking a little too pleased with myself after having defended my dissertation at Michigan back in 2007. But what I want to say about Mark up front is just that he always described his role as a facilitator, that he would bring us together with other people from a wide variety of backgrounds, experts who had detailed knowledge in different disciplines. And the common theme amongst all of us who work with Mark was that we would be multidisciplinary in thinking about how ecological factors, environment influence infectious disease. But you could cast the net in many different directions. So I was working with Dan Brown, who's now at Washington. He was the Geographic Information Systems professor at Natural Resources School. Anna, who's now at Drexel on the DSRU. She's a fantastic social epidemiologist and methodologist. Not pictured was Shandy John, now at Indiana, who's an infectious disease pediatrician, taught me what I know about the biomedical aspects of malaria. And just to illustrate, I was working on classifying satellite imagery and thinking about how the environment affects risk of malaria in the Kenyan highlands. And we did object-based classification up at the radiation laboratory on North Campus, a place that I did not know existed. But I think through Mark's push to always look for other experts who could help, to bring different disciplines to bear, I went up to the rad lab and worked with a man who would invent robotic hands in his house during the evenings and then bring them in to show me while we would classify satellite imagery during the day. I learned enough entomology to be dangerous. Mark has had an appointment at the biology program as well as here. These are the vectors of Chagas disease, disgusting little creatures if you've ever encountered one. And the first project actually that Mark put me on when I was doing my master's was to study the potential effects of global warming on cockroaches. I don't know if you remember this. Nothing ever came of it. We did not publish it. But I think if we need another lever to pull with our politicians to think about global warming, perhaps thinking about the increase in cockroaches could do the job. It's very visceral when you think about it. And then I think one of the common themes with Mark's work was always putting the people into the center of these infectious disease cycles. I was looking at satellite imagery and trying to link it with numbers on an Excel spreadsheet, but I think Mark always pushed us to think about the people and to make sure we were working with the communities who were actually affected by these diseases. So these are the Kenyan highlands, people irrigating, which could reduce their risk of malaria. It might increase their risk of malaria depending on how good a job they do with their irrigation and the standing water. We have deforestation, people creating pastures for their cattle, chopping down trees for economic reasons. And we've always thought about how these complex interacting factors work together to affect risk and to affect human health. So another little area that I think I started to bring into my work at Michigan was history. And I'm going to start my malaria component here by going back to Ronald Ross. And I think this is appropriate because although Ronald Ross is known for having discovered that the Anopheline mosquito transmits malaria, he was actually a polymath. He was also someone that tried really hard to bring different strands of evidence and different areas of work together to better understand disease. And actually, perhaps that's overstating. When he was in medical school, apparently he spent the whole time writing plays and music. He was kind of a dabbler, I think. And so the day that he discovered that the female Anopheline mosquito is the vector of malaria, he wrote a poem to celebrate. That's how he processed this earth-shattering discovery. And I won't read you the entire poem, it's on Wikipedia, you can go read it, but at the end he says, "I know this little thing a myriad men will save. O death, where is thy sting? Thy victory, O grave." So I think we can agree Ronald Ross was a bad poet. But I think the point here is that getting outside your comfort zone, which arguably he was comfortable writing bad poetry, is a good thing. So I'm going to stick with history for a little bit, just because we have such a long history in malaria, I think we need to learn from it. Those who do not are doomed to repeat it. So I'll jump forward a few decades of malaria history to DDT, which, as you know, is probably the most effective tool we've had against malaria, certainly the most notorious. And this is Paul Mueller, who won the Nobel Prize for the discovery that this compound could kill insects in 1948. He didn't invent DDT, the compound, he just figured out that it was a very potent insect-killing chemical. And this is my favorite photo of DDT in action. This is an Italian spray operator in 1945 spraying what we call indoor residual spraying with insecticide. Still essentially how it's done today. However, today we use better protective gear. Mostly the spray operators are not smoking pipes, and they try to remove the terrified children from the houses before spraying. But it gives you the sense of the times, I suppose. And this kind of indoor spraying was so effective that it did catalyze a global movement to try to spray as many houses as we could, kill as many mosquitoes as we could, to try to eliminate malaria in as many places as possible. And today that period is referred to as the Global Malaria Eradication Program. This is an article from my hometown newspaper, New York Times, from 1957, talking about how the Eisenhower administration was committing to support this program with a generous financial contribution to the WHO's special account in order to try to eradicate what I think we would now call eliminate malaria over much of the world in 5 to 10 years. And the stated reason for why we could do that was because we had these remarkably effective poisons in DDT and its related compounds. Furthermore, the fact that we were beginning already to see resistance to DDT was quoted as the main reason that this was an urgent thing that we had to do. We got to get out there and use DDT, prevent malaria before we lose this incredibly potent tool. So these programs all were structured essentially the same way. You started off with a parasite reservoir, so some fraction of your population that was infected with malaria, and some amount of transmission from that infected population. There was a preparatory phase during which you would map all of the houses in your affected area, and you would get your teams ready. You would train up these IRS teams, you would get all the insecticides you required, and then you would start an attack phase, which was generally 3 to 5 years of total coverage of DDT spraying in these communities. There were very draconian laws passed to enable the complete coverage with this tool. Things like saying you may not live in a house that hasn't been sprayed, or it is illegal to refuse a spray team from coming into your house and spraying. The result was that they achieved extremely high coverage. And the theory, which in some cases proved correct, was that if you killed enough mosquitoes, transmission would stop quite quickly. And if you could keep those mosquito populations suppressed for a few years, infections should resolve. And when you would stop spraying, malaria should not come back. This worked in some places. It did not work everywhere. And it was not tried in many of the most endemic parts of the world. So Europe, what I'm showing you here is a George McDonald paper from 1965. And the dotted bars are the more successful programs. Not saying they sustained these gains, but they were considered to have consolidated or eliminated malaria. Here in Southeast Asia, you can see a lot of programs where attack was ongoing and ultimately not successful. And then you can see the parts of the world that never even began to be covered by these programs, notably Africa, which at the time was known to have the highest rates of malaria in the world. So I think it is important to know that this was successful in places like Europe. There were a number of successes in the Americas, although those were predominantly islands, places like Cuba, which eliminated malaria in 1973. But we didn't see success from a number of the places in the world that should have had it, and we didn't even try elsewhere. What we tended to see in places that attempted to eliminate malaria through this approach, but did not achieve it, is a result over the 1970s, something like Zanzibar. And Zanzibar is a very clear example of a phenomenon that happened globally. So you started off with parasite prevalence, the fraction of kids that were infected would be measured by surveys. And within just a couple of years of spraying, you saw massive reductions in prevalence. So the DDT approach was very clearly effective, and that was maintained year after year after year. In 1972, again, a New York Times article, a new leader came into Zanzibar by the name of Sheikh Karume. And Sheikh Karume, who is described here as an ill-educated former dock worker by the New York Times, states, everyone knows that Africans are malaria-proof. And I think if you lived in Zanzibar at this time, this is now 1972, you can kind of understand the sentiment. They've been spraying year after year after year, and they aren't seeing any malaria. No one has really experienced high rates of malaria in a decade at that point. Sheikh Karume kicked the WHO team that was leading the DDT spraying out of the country. The program was entirely halted, and over the subsequent years, we saw a massive resurgence of disease. Maybe not back to the 80% where we started, but to what we would consider to be extremely high transmission rates. And I wish I could say this was an isolated event, but we started looking at the literature, and you can find these stories over and over and over again throughout the 1970s and 1980s. We found 74 of them. And almost all of them are attributed, at least in part, to programs that stopped doing the basic things that we think programs ought to do. And the primary reason for that was that they didn't have any money. So Sheikh Karume would be on this side, where he simply said, we don't want to do this anymore. And you see many examples of that. But you also saw programs that really wanted to keep up the energy, but they couldn't get any more funding, whether that was international donor funding or whether that was funding from their own government that said, why would we give you more money for a disease that we no longer have? This is not a malaria unique situation, right? This is a paradox of public health. Whenever we reduce disease down to some low level through our effective interventions, we are going to face this challenge, the out of sight, out of mind challenge. And as long as we still have some intrinsic risk of disease in that place, however, if we stop what we're doing, we can expect that we will see resurgence of disease. For malaria, it is true that that top line probably changes over time. And there's certainly places in the world where we've reduced malaria, and then we've had, say, urbanization or deforestation change that intrinsic risk, such that we probably could stop our programs and we wouldn't have to risk this massive resurgence. But we obviously should be very careful about that sort of decision and not assume that we can stop what we're doing just because malaria is low. As someone who works a lot with governments and thinking about how to fund their programs, the challenge you see here is that decision makers tend to focus on what's below this line. You say, we only have a little bit of malaria, so why are we spending all this money on trying to get down from very low levels to no malaria? And of course, what we'd like them to be focusing on is the benefit that is above the line, the fact that you are actually achieving things every year by continuing to invest in malaria control. But that's a hard thing to do. And I think vaccination programs obviously suffer from the same challenge here in the US. It's hard to keep people funding something when you can't see what it is that you're trying to fight. So I take a few lessons from this. I mean, the first one that I hope is obvious is that we have to keep up funding for these programs. And we should expect that keeping up that funding is going to get progressively harder over time, especially once we're successful. So there is an onus on malaria programs, I mean, ostensibly other disease programs, to try to spend all of the resources they have as efficiently as they possibly can. We can't expect that the donor funds will always be there year after year after year. The other thing that I think we have to think about is how do we get out of this cycle where every year we're spraying chemicals year after year after year with donor funds for the most part. That is inherently going to stop at some point. And the history of malaria is that 72 times it stopped, largely because we stopped getting the donor funds, sometimes because the community said, we don't want you to spray here anymore, sometimes because the government said, why are we doing this? So I think we have to think about how to get out of this cycle. There is one potential answer, which won't be true for everywhere right now, but I think is intriguing. So the UC San Francisco group reviewed all of the past elimination programs that they could find. They found about 100 of them. And they found that about half of those were successful. They got rid of malaria from whatever place they were trying to, and about half were unsuccessful. We took these and we cross-tabbed them with that review of resurgence events that we looked at. And what I think is interesting, well, perhaps unsurprising, is that if you were unsuccessful, you reduced malaria to some low level, but you didn't get rid of it altogether, almost every time we found documentation of malaria coming back. And I would actually expect that it probably came back in almost every single one of these, but perhaps it wasn't in the literature for the other 13 cases. But programs that eliminated malaria did not see that. We found a few, and those are generally ones where the public health system falls apart, the Russian republics, for example. But there aren't many. Now, I won't get into all the potential reasons for this. I think you're probably already thinking through some. These were richer countries. These are European countries in many cases, so more temperate places that probably had lower risk of malaria to start with. And these things are true. But I think there are also potential biological reasons why elimination is a more stable state, at least in certain settings where you're not seeing massive amounts of imported malaria from other places. And those are things such as the fact that if you have an outbreak after immunity is waned, it's much more severe. There is some evidence that mosquitoes may not be as amenable to infection by foreign strains. So there are things that could explain this beyond simply these are programs that were easier. And I think those give us some hope that there is some way out of that trap in certain places. I think Hispaniola is one of those places. It's the only island in the Caribbean that still has malaria transmission. Again, Cuba was the last one, 1973. No other island has had endemic malaria. Haiti still has endemic malaria every year, and we're spending about $3 million every single year on malaria control on the Haiti side of the island. Dominican Republic is spending even more. If we can invest in the short term to clear out the island, we can stop a lot of our expenditure, and it will be a good decision in the long term. So this is the recent picture of malaria, and I should probably update this because the last couple of years have been interesting. But you can see the massive increase. This is only donor funding, up to about nothing in the year 2000 to nearly $2 billion every single year. Domestic endemic countries contribute another $1 billion on top of this, which has been entirely flat over this period. And that's a story that I won't go further into, but clearly something that's going to have to change if we're going to be successful. You can also see that this donor funding has largely plateaued. It's not going to keep going up the way that it went in the mid-2000s. The largest of the donors here is the Global Fund, and the second largest is the President's Malaria Initiative, of whom we have an eminent representative here today. The largest donor to the Global Fund, does anyone know? The United States. So your top two donors are the United States. And if you've been following the news lately, I think that should make you very concerned. It doesn't take a lot for a donor to reconsider its priorities. And we're very thankful, and I think the world is thankful, that the US government has continued to invest in malaria, actually increased its contribution to malaria year after year. But I don't think we should assume that that will always be the case. And we started saying this, I think, 5 or 6 years ago, and people were like, yeah, the donor funding is fine. And I think today you can understand why we do need to be considering what our alternative options are, and to start planning now for how we're going to fund these things in the future when maybe the donor funding is no longer there. What having all this money has allowed, however, is the scale of effective tools. And we do have highly effective tools for malaria, and they're not very expensive. We have artemisinin-based combination therapies. Those are effective drugs, and we're now buying somewhere between 300 and 400 million of them every single year. We have insecticide-impregnated bed nets. We're buying upwards of 200 million of those every single year. And these tools have driven down malaria. This is the number of cases just in Africa, and you can see it increasing with population growth in the early 2000s. Since we started scaling up these tools, incidence has come down. Now, there is evidence that this decline is not going to continue, that it may have already plateaued. And I think we need to be very concerned about what we're going to do about it, because this largely resembles that hypothetical graph I showed you. We're suppressing every year through our energies, our expensive interventions, and we need to think about how what we're going to do next. I think one hint comes from when you start looking at, say, bed nets, which I think is where the majority of that donor funding goes. So on the left is now a slightly out-of-date paper by my colleague Nora, who's at WHO now. And on the top, this is Kenya. And the spikes are the population centers of Kenya. So the big one is Nairobi. And they mapped first where they thought malaria was particularly highly endemic in Kenya, so around the lake there on the left. And then they mapped as best they could the coverage of bed nets. And they found that those two things did not correspond as well as one might hope. The nets really weren't being targeted preferentially to the places that had the most malaria. And there are political reasons for that. Kenya, of course, has tribal dynamics, which makes it quite hard to say, well, you can have nets and you can't have nets. But there's also just, I think, sometimes a lack of surveillance information underlying the distributions that we do. This is a much more recent analysis by the Malaria Atlas Project at Oxford. And when they looked at nets across all of Africa, and they looked at how many nets go into each country and what coverage is achieved by those nets, what they found was evidence of substantial over-allocation. That you had certain households that are getting nets over and over again, and other places where you're not getting enough nets. And they did not look at which of those houses were which in this paper, but the hypothesis, I think, should be that the ones that get nets are the ones that are more accessible, which may not be the ones at highest risk of malaria. Now, we've been here before. We have two successful examples of disease elimination programs that eradicated disease from the earth. Not extinct, but eradicated. So I think we need to look at them. And what I find fascinating is that both of them tell us the same story. So this is rinderpest, the second of our infectious diseases to be eradicated. And it's a cattle disease, if you're not familiar with rinderpest. And I find this story from Jeffrey Mariner fascinating. So this is just talking about Ethiopia. What they were doing is vaccinating cattle against rinderpest, and they were delivering about 20 million vaccinations, 21 million every single year for this period of time. And when they went out and they did surveys, what they found was they were achieving extremely high coverage of vaccination of the cattle herds that were most accessible, but low coverage in the least accessible cattle herds, which again may have been the ones that were at highest risk because rinderpest continued to be found in the cattle populations. What they did in response was begin to invest in surveillance. They started paying the cattle herders to actually report when they found the boils on the cattle and to actually even deliver the vaccine themselves. And they reduced vaccination from over 20 million down to less than 3 million and eliminated rinderpest from Ethiopia in 2 years. Vaccinating the cattle that mattered most, rather than trying to do everything everywhere, was the solution there. And you find exactly the same stories in smallpox. House on Fire by Bill Fegge is a really nice account of this. But this is one story I pulled out from Central Java. So at the time, WHO's recommendation was smallpox vaccination should reach at least 80% of the population. That was success. There was not good math behind that, for the record, but that was the benchmark that you were shooting for. Java had achieved more than 95%. So by WHO standards, these guys were doing a fantastic job. Yet smallpox outbreaks kept going year after year in Java. And when they would look, it was always in that fewer than 5% of people who hadn't been vaccinated. So again, you can vaccinate everyone you want, but if you're missing the populations that actually have a disease transmission, you're not going to be successful. What happened in response, again, is that they shifted to what they called containment. And they started looking for smallpox. They would vaccinate people who had been in contact with people with smallpox, and they greatly reduced the operational effort while focusing, again, on the people that mattered most. So I think our BENNET story, at least the one that was documented a few years back, is highly similar, and I think you can begin to see how maybe we can do a better job. The challenge we have is that it's easy to say that, it's hard to do it, right? We're going to have some really difficult changes in how we do our operations in order to improve these things. D.A. Henderson, who was the WHO director of smallpox, said to make these shifts required 10% technical skill, 90% organization and leadership. And Bill Fegge, who led the program in Nigeria and India, kind of similarly said the real problems of smallpox were routine, supervising, motivating, evaluating. And they required managers, administrators, logistics experts, people who knew how to solve problems and get things done. The program would not fail for lack of scientists, but it could fail if we didn't attract the best managers. I'm not trying to dissuade you from being the technical people. I know who I'm speaking to in this room. And I think we continue to need really good technical thinking. And we need to bring epidemiology to these programs and figure out how to deploy it in a way that helps us run programs better. What we've been doing at CHI, though, is trying to think also then about the other operational side. How can we be multidisciplinary and not only working with the epidemiologists and the technical people, but also starting to bring in other folks who can help out with those operations? And I hope you hear echoes of Mark helping me to think about different expertise areas and bringing them together to think about malaria. That's what we've been trying to do at CHI. So then let me just introduce the organization very briefly. We're the Clinton Health Access Initiative. We were part of Clinton Foundation back in 2002, although we are now our own separate nonprofit, entirely independent. Bill Clinton and Chelsea Clinton continue to be on the board. When President Clinton and IRA Magazine started CHI back in 2002, this was sort of the mission statement that they used, that global health was a problem crying out for organization, entrepreneurial skill, and that for a relatively small amount of money, we could try to have a huge impact. So the way we do this is we work directly for governments. We ask, what can we help you with? What are you trying to achieve? And then we embed staff within their programs in order to help them do it. So our people tend to be generalists. We have technical people. We have some people who come not necessarily from public health. And we work to build systems that we hope can outlast our involvement in those programs. Our goal is always to transition out and leave behind a program that can run itself into the future. As I say, doing that is tricky. It requires people who know how to get stuff done, who can handle the politics, the frustrations of working through government-run surveillance and response systems. And we are a mission-driven organization that tries to work with urgency, humility, and frugality, which means we don't pay our staff very well. But this is our current footprint. Sorry, it's not a great slide. The very light blue countries are what we call our procurement consortium countries. So we do a lot of work negotiating drug prices with pharma industry, with the diagnostics companies, and these are the countries that access our pricing agreements when they buy their own commodities. The darker two blue countries are the ones where we actually have programs. West Africa is not well represented here, which as the malaria lead for the organization is distressing to me. I think it's in part because we are an American NGO and don't have a lot of French speakers. So if you are a French speaker and are interested, you should come talk to me. So what I'm going to do for the remainder of my talk is I'm going to give 3 examples of how I think we're starting to make that shift from mass approaches to think about how we use surveillance and surveillance-driven approaches to better target and tailor what we do. And so I'll give you three kind of pieces of that surveillance spectrum. The first is how do we actually get out and get better information in the communities where we need to understand what's happening. That'll be from Panama. The second, in South Africa, I'll talk about some of the actual informatics components, some of the things that Sharon talks about in New York City, but much worse. And then the third part will be about how do you use the data that comes out of these systems in order to better inform your decision making. So let's go to Panama. So Panama doesn't have a lot of malaria, but it has a persistent malaria problem. And you can see the number of cases peaked at around 6,000 back in 2004, and since then have just settled into this plateau where they're not going up, but they're not going down. And part of the reason for that is that malaria is very focalized in remote indigenous communities, particularly on the Caribbean coast. These places have very poor access to healthcare. They are semi-autonomous, so the government likely doesn't view them as an urgent priority. They aren't the people who they see in the capital cities who are definitely voting. And so you have these kind of neglected populations in which malaria is still a fairly large burden of disease, but which the government is not pushing hard to get rid of. Here's an image of one of the islands off the coast so you get a sense of the communities that we're talking about. It's a beautiful part of the world, but very, very poor communities, and it takes a really long time to get out to some of these. So you take a boat along the coast. Some of the communities have such rocky coastlines you can't even dock the boat, which is interesting when you are providing healthcare via technicians who come in on those boats, ask, is anyone sick here, takes a blood slide if someone has been, and then swims that back out to the boat with your paperwork, and takes that microscope slide back to the lab to be read. Some of the days that we've been out to visit, the microscopy lab is not functional, and the slide has to go to the Gorgas Institute in Panama City. And the result is that it would take up to a month before you got your diagnostic results. This is not a great situation, and it's one that it wasn't a technical challenge. We knew we had the tools to fix it, and so our job was to work with the Panamanian government and directly with the Guna authorities in order to try to rectify it. So over the last year and a half, 2 years or so, we've been working on extending a malaria case management program via community health workers. There were community health workers out there. They were not providing any kind of malaria diagnosis or treatment. This is a map of cases reported in just the Gunayala, which is the first comarca where we started working over the first year. And what you can see already that I find fascinating is just even within that area, which on my map that I showed is just red, right? So it's being reported as there's malaria here. In fact, you see substantial heterogeneity. You have certain villages that are responsible for most of the cases and certain ones that didn't see a case that entire year. Now, the community health workers are using rapid diagnostic tests. They're still taking blood slides so that we can confirm that the RDTs are working well. It's mostly Vivax here, which if you know your rapid tests, the rapid tests are not as good for Vivax as they are for falciparum. But we're seeing some pretty good results. This color doesn't show up well, but we have increased the total number of cases being observed, and the majority of them are now being observed by this community health worker network, who are achieving much higher positivity rates in their testing than the old method of having these technicians go out to the community and have people try to make their way to health facilities. So we seem to be finding malaria better. We, of course, want that positivity to come down as we test more and more people and as malaria rates actually do decline. So expansion is underway. We're now extending this community health worker network to the next 2 comarcas. Which is exciting because these are places that, although they are less than 1% of the population of Panama, they're about 1/3 of all of the cases. They're not coastal, so these are much harder places to get to, but we have the agreements with the Guna authorities, and things are progressing nicely. Panama changed their policy in response to that first year result, so anyone can now use rapid diagnostic tests, which we think is a great step forward. And we've transitioned back that first program in the Gunayala to the government technicians. So they're now in charge of providing all supervision. They have tablet computers nicely sealed in these waterproof bags. We'll see how long that lasts. But the program is government run and fully endorsed by both the government and the Guna Congresses. So we're very optimistic that this will be something sustainable that we'll be able to keep in place with high quality. And the other piece here that's exciting is that now that we know which of these actual communities are the ones with the malaria, we can start to go in there and figure out what's going on and what we can do to get rid of malaria besides provide good case management. So the government is doing some active entomology right now in order to investigate breeding sites to see if there are obvious things that can be done, like channeling seawater into certain coastal ones, interviewing the families in order to understand where do they sleep, when do they contact mosquitoes. So there'll be a pilot of insecticide-treated hammocks getting underway since most of these communities actually sleep outside in hammocks. So it will be a logical intervention that should be able to help. But again, having that surveillance data is what allows you to ask very specific questions about what's going to work in this place rather than what is a generic tool that works in other places. So we're getting better data out of this system because now we're testing for the first time on an ongoing basis in these communities. Whether the test is positive or negative, that is an information point that we want to capture in a surveillance system. So let's go to South Africa, where this is what the surveillance system looked like a few years ago. An assessment was done, and it doesn't look that bad, I guess, but it's a pretty flowchart. But what you have in South Africa are 3 different endemic provinces. Each province did its own thing. They have their own surveillance system, they have their own forms, and they report separately into databases that don't really talk to each other because they don't even have common variables that can talk to each other. Information on interventions was collected entirely separately. It's in a different database, doesn't have identifiable units that you can use to merge those 2 things, and it becomes really hard to ask basic questions like, is the DDT spraying that you're doing working? Is malaria going up in places where we have higher coverage or lower coverage? Is there resistance to our DDT? The things you would want to know to run a program well. So the request from South Africa was to help them build an integrated malaria information system. So the first year of this work was working with stakeholders in order to discuss what do you want to see in the system? How should it work? How will people report? Working with WHO in order to define all of the indicators that would go into that system, making sure that we had buy-in both from the national level, the federal level in South Africa, as well as the individual programs in each of the provinces who work quite independently. The result of that was this diagram that we would introduce electronic reporting in certain places, although not everywhere, because paper-based is still better in places where you're not going to have good cell phone coverage. And either way, though, paper or electronic would feed into an integrated database where you now also have all your intervention data going in and sitting nicely together. This is built in a program called DHIS2, which is now the most common health information system software that's used in programs throughout the world. There's no particular reason for that. I don't know if any of you are DHIS2 experts, but it's a pretty clunky program, but it does work. It does enable web-based dashboarding, web-based entry, and so it's much better than the way we were doing it before, which let me just show you a couple examples of that. At top are the forms that you used to have for the 3 endemic provinces, Limpopo, Mpumalanga, KwaZulu-Natal. Just, you can see that they're different. They are now unified into a single form. We have common indicators, and you're collecting the same information. So we can actually start comparing across the provinces of one country. And these are the dashboards. It was done in Excel, and you have to update that Excel spreadsheet with new information as it comes in, which is fine, but it limits the ability of using that dashboard in order to allow decision makers across your health system to make decisions based on that information. Now we have the DHIS2, which allows some pretty mapping and things like that, but even better, it allows more users to access it through password encoded access. So we've gone from 5 to 50 users as of now, and by Q1 next year, we should have 140 people at different levels of the health system who are all accessing information. So last, I'd like to talk a little bit about the use of those data. And I'll go to Namibia for this. And I think the story here is kind of similar at the beginning. Back in the early 2000s, they had the right policy in place, which was that you should test people who are sick with suspected malaria. But it didn't happen. We don't even have data on test reports because they weren't even collecting it. Once they started collecting that information in 2008, we see very, very few tests being conducted. The result of that is that the information that they had for decision making was weak. This is how malaria was defined for years in their national plan. So this is Namibia. The northern border is with Angola, which is a much higher endemic country. And so they define risk in 3 strata. You had your very high endemic risk in your north, you had moderate risk, and then no risk. That's true. It remains true to this day, but it also describes more than half of the entire population of the country living in that top zone. It's not a very targeted stratification, which limits the amount of impact we can get with our resources. So around 2011, 2012, we started helping them to try to improve the adherence to this guideline. How do we make sure that our health workers are actually testing our suspected malaria cases? I won't get into the details, there's a paper on this, but Namibia is the 2nd least densely populated country on Earth. So going out to visit every clinic is a really hard thing to do. So the approaches that they trialed were called trainer of trainers, right? Which is where you train expert trainers and they go out to different provinces and they train trainers and those trainers go out. So you try to disseminate information through a waterfall network. And we tried a bunch of other things that we thought would help, like follow-up SMS messaging or providing mentoring services. The main point is that providing better training helps make sure that people actually follow the rules, right? So as soon as they started doing good education, we started to see increases in confirmation rates. Now, once we have confirmed malaria, we say this is actually a malaria case, we can begin to get more information about where malaria transmission is truly happening. So in the next year, the country started classifying their cases according to the likely origin of where that person got infected. And of course, when you face a stark divide across your border like this, that's really important. So Angola is to the north, and you have Namibia to the south, and you can see how the incidence is quite different on either side of the border. I don't have a data set I can actually share with you on the origin of the cases in Namibia, but I'll show you one instead from Swaziland, now Eswatini, which is just on the other side of the continent. And Namibia has similar information, but hasn't made it publicly available yet. So these are the locations of cases that were identified in Swaziland, but who said that they had traveled somewhere else during a biologically plausible window of time before they were identified at the Swaziland health facilities. And we asked them, where have you been? And so then the Swazi team goes through and says, where is it most likely that they were infected? This is an imperfect process, but it allows you to start getting the general idea of where your malaria is coming in from. And you can see there are substantial locations up the Mozambican coast where it gets higher and higher endemic as you go up, where most of these people are going to visit friends and family, and then returning with malaria infection, which then sparks continual series of outbreaks in the country. I think the good news is that by doing this sort of case investigation, both of these countries, Swaziland, Namibia, also South Africa, they're starting to be able to work with their neighbors to target malaria money to the places where it's actually going to affect their problem better. So this is an example from a regional grant application that's just gone into the Global Fund from Namibia and Angola and Zambia, where they are investing in some of these provinces across the border that are actually the sources of the malaria cases in Namibia. And we can see the same thing happening right now in Swaziland and South Africa. The South African program has actually just gotten approval from their government to pay South African health budget for interventions in Mozambique for the first time. It took about 5 years of working through the finance department to make that happen. But I think it's the right decision by South Africa to say we're not going to just spend our money within our borders when it can be more effective helping the Mozambicans reduce their malaria such that we see less coming into our country. So as we get better and better testing, and you can see that just in the last year, they've started doing active surveillance for malaria, to go out and find remaining pockets of it, and that's greatly increased the number of tests done per year. We begin to be able to get much better maps. So this is still an administrative unit, but we can begin to break off that zone into places that have different rates of malaria, and that means we can start prioritizing our resources accordingly. So once we knew more or less where malaria actually was, we could start mapping those places so that we could intervene in a much more specific way. So this is not something a malaria program should have to do. Ideally, you would have a demography department in your government who would be doing censuses and who would have nice maps. That wasn't the case in Namibia, so the malaria program took it on. We helped the malaria program map every single village in Namibia, which had never been put on a map before. If you went out and you talked to someone in the village, they say, I live in the name of a village. And you would say, well, how far does your village go? And they said, well, over that away. And so we tried to define the bounds of every single village because they're doing indoor residual spraying campaigns. And as back in the 1960s, we need to know where all of the structures are that we're going to spray if we're going to do a good job. So once we had all of these villages mapped, we could then go to satellite imagery and do remote enumeration of all of the structures in these villages. And that now serves the basis of the indoor residual spraying program in Namibia, which is currently underway for this year. So we can look at all of the different structures, all of the different villages, and decide which ones we want to spray based on risk. This is an ugly map, I apologize, from actually a couple of years ago. But the idea is that you can overlay where we find our likely malaria transmission areas with where we actually have population settlements, and then we can send out our spray teams armed with technology so they can pull that up, and they can see where they are, they can see which houses are in their area, and then they mark when they spray a house, and if they don't spray the house, they say, why did we not spray the house? And we can begin to track that information much better. And so, for example, in this illustration, you see a lot of structures where there are no marks. The old way you used to calculate coverage of your indoor spraying campaign was simply saying, we went to this many houses, we sprayed this many houses, put the one over the other, and that's our coverage. The problem with that is it's wildly inaccurate if you didn't go to a lot of houses that you should have gone to. And so this is, so now that we have technology, we can calculate much better metrics. This is a real shot from the Namibia spray program, which is underway. This is, I think, week 1. We started to be able to see which villages they were spraying. And this is what happens when you start using the proper denominator for your spray campaign. For years, they were reporting 90% coverage because they said, well, of all the houses we went to, every 9 out of 10 we sprayed. When you actually go out and do a population survey, you find that most people reported that their houses were not sprayed because they were never included in the denominator. And over the last few years, the coverage that the Namibian government actually measures has gone down, but it now matches the survey data. So for the first time, we actually know what we're doing, which is the kind of a useful first thing if you want to then be able to improve it. So I'm going to finish up here, and just to kind of come back to the idea, I hope you could see how different expertise is required to do this sort of surveillance-driven interventions well. We need the guys with the technology. We need to have good IT professionals who know how to work web-based databases in a way that I do not know how that works. We didn't have a course on that at Michigan when I was here. Is that going now? So we need informatics professionals who can stitch together these things in a user-friendly way. A lot of these spray teams are not people who are literate. They have never seen maps before in some cases. The idea that you could look at Google Maps and see the blue dot, that was a very unfamiliar concept to people. And so we ended up actually not even using maps in a lot of these applications. But you need people who understand how to invent software that works for people and then the hardware that goes with it. You, of course, need the people who are doing the actual diagnosis and treatment. This is the community health worker cadre that is now providing malaria testing and treatment in Namibia for the very first time. This just started about 6 months ago in Namibia. As I say, incredibly sparse population. So very hard for the population to access health services in many places. Now, for the first time, we are providing community-based testing and treatment, which should go a long way. And if their information can feed into that good information technology, it will become all the more powerful. We then need to figure out how we train people well and making sure they follow the guidelines. This is actually just last week, a shot of the district level surveillance agents having a refresher training where they're told both how to supervise the community health workers, also to think about how do you use the DHIS tools. And so we have to have really good educators who know how to keep everyone following the right rules. I didn't even get into the supply chain and the logistics side, but it's horrible. You need people who know how to get products delivered to the places where they need to go so that these guys are armed with the rapid tests they need, that they have tools that work, and that when spray season starts, you're not left saying, actually, the insecticide isn't here because the boat was in a storm and it missed its port, and now we're going to delay everything a vital month, which is, in fact, what happened. Then, of course, it's not just about the malaria case data. We need to make sure we're measuring our mosquitoes, that we're integrating information. This is the new insectary that Namibia has just built. I mean, the building was there, but it was not functional until the last year. We now have a revitalized entomology department that's thinking about doing susceptibility testing, finding out that a lot of the insecticides it was spraying actually were not working, that you had rampant DDT resistance in certain parts of the country, and now, for the first time, introducing new tools that can address that kind of resistance. And then to bring it back, at the end of the day, this is about having the community support and having the community interacting with these programs in a way where they're supportive and that they see that it's benefiting themselves. These are folks in one of the northern towns who are working on household improvements. They had their youth service work. We brought in some architects who do some pro bono work, and then they helped the youth service identify local tools that could be used to screen windows, to put better doors on, to patch up some of the gaps in walls. And we don't have any scientific evidence that this helped, but I think it's a sort of community-driven program that could go a long way if we could figure out how to do it well and how to capture that kind of information. So multidisciplinary work is good. I'll just end. This is our website, clintonhealthaccess.org. If you'd like to learn more, we do also hire people periodically, including people with master's degrees. So please be in touch if that's of interest. One of the things I remember, Mark, about I think we were at a conference where you got really angry at someone's talk where they said that we had to be careful about letting advocacy slip into the science that we did as public health professionals. And you stood in the back of the room and said, we are advocates by the nature of being public health scientists. We're not just basic scientists. We are trying to improve people's health. And I think that's something I've taken through my career to date. It's just that we need to do really good science. We have to figure out what works, what doesn't work. We have to figure out how these systems can improve, and we need statistically robust evidence of what we do, that it's worth it, and that we're spending donor money appropriately. But we need to do it in a way that we don't lose sight of the fact of who we're trying to help, which are these endemic communities. So thank you very much. Happy to take any questions. Yes, sir.
Common to the current initiatives to use like gene drivers to not drive down or clean like mosquito population. Sometimes you see that fitting into this like malaria campaign.
I think there's a lot of exciting ideas out there. And gene drive is one. If you don't know, it's where you genetically modify the mosquito, so you might crash the entire population. We're a very long way from having those tools. Whether you think ethically gene drive is a good one or not, we're not going to have that for 10 years, 15 years. And I think our position has always been that today we have effective tools. Now, even our effective tools wax and wane in their effectiveness. Pyrethroid-treated bed nets aren't working the way they used to due to resistance, so we have to be ready to get out new tools as they become available. But I think we're very focused on how do we make sure that we're getting the biggest impact we can today with the tools that are available. All for researchers pursuing new ideas and new things that might make our job easier. A vaccine would be really nice if anyone has one. I think being able to kill mosquitoes by dropping genetically modified ones out of drones still sounds like science fiction, but I can believe one day it'll be a tool that could be useful. Yes. Jim.
You make a strong argument that improved management, improved allocation of resources, I think, can make a big difference. And you give the example of the Indian villages in Panama, where we're focusing. And indeed, that is undoubtedly true. But one of the key question, I'm really interested in polio eradication. And polio eradication decided 10 years ago that they had all the science that they needed.
Mm-hmm.
And so now we're in a position where the eradication program is under serious threat. One of the questions is, how do we then look ahead and say, what are we going to need? I mean, you already gave us the great scenario. You did this very eloquently about, you drift along and then you reach these problems and you shoot back up. And of course, malaria has all these examples of developing resistance that could do that. One of the key things is to say, what new scientific knowledge is the key thing that are going to be necessary to reach the goals that you're setting for. Using the context that you're going, that you're saying right now, that we can have these administrative things, but administrative advances. But once you have those advances, to be able to project where the problems are, what problems are going to be, what new knowledge is needed to avoid those problems. Mm-hmm. Now, I understand Kim Lindbergh is going to tell us how to solve the problem.
Yeah, no, so Kim's from WHO, so I would defer to her to say what we should do. My job is to help make it happen. But I think you're exactly right. And I think what's interesting is that if you go back to 1969, when we officially said that maybe elimination wasn't going to happen in every country, the call then was, well, we're not saying we're not going to get to eradication. We're simply saying that we're going to need new tools. We're going to need to think about how do we bring down the burden of disease in Africa to the point where it's feasible to start doing something beyond kind of a blunt force approach. They were saying things that are very similar to what I think we're still saying today. The difference is that we have a really strong pipeline of new tools right now. We have more drug candidates than I think we've ever had before. So even though there's risk of resistance to artemisinin spreading, we have potential drugs in the pipeline. We have right now, for the first time, multiple insecticides. Three new types of insecticides are going to be available for indoor spraying. We have new classes of insecticide-treated bed nets, including dual insecticide nets for the first time. We're in a really good place in terms of having tools, not just things that are maybe in 2025, we might start talking genetically modified mosquitoes, but things that we can start launching really soon. Where I think we've fallen down a little bit is in terms of the information infrastructure required to think about how do we use those things in the most effective way. I couldn't tell you right now which countries require a dual insecticide-treated net versus a different type compound for indoor residual spraying and how those two things would interact. And if you're driving the mosquitoes out of your house due to repellency of the one while you're losing the killing action of the other, these are complicated questions where we need modeling, we need better surveillance data, not just on the case data side, but also the entomology side. And I think we will begin to start getting to that point where we can say, oh, you know what we need is a compound that works in this mode of action, or a drug that is a single dose and lasts this long, or a surveillance tool that fills a gap. I think we're starting to get to that point, but I fully agree that it's still a need.
So is there a collaboration between the kind of efforts that you're doing and the kind of deeper analytic efforts that the Oxford group or the Swiss group are pursuing?
Yeah, I mean, I think that's one of the things that we've been able to help with, because we have the people who are based with the programs embedded, and then we have technical people who are aware of all of the work that's being done in the academic settings. It's incredibly helpful, but it doesn't necessarily find its way down to governmental programs. So a lot of the managers in these programs don't have the time to read journals. They may not have journal access. They often are not able to go to conferences because they don't have the funding. Their job often is simply to fill enough of the checklists out that they can keep the donor funding coming in. Are they keeping the global fund happy? Are they hitting their milestones so that the money doesn't get turned off? That doesn't incentivize them to think about the problems that they would like to be thinking about. So I think one of the things we've been able to do is to form explicit relationships with groups like mathematical modelers, geospatial people, groups who are doing the work that is incredibly useful for planning right now. It's not theoretical, but to try to make sure that there's an interface for those groups to directly engage with programs. So in the case of the Malaria Atlas Project, which is a great group out of Oxford, if you haven't looked at their stuff, I encourage you to go to their website. We have an explicit partnership with them. They're a WHO collaborating center, so they have the endorsement that they're doing good work. And then what we do is we sign agreements with the countries to enable their surveillance data from health facilities to go out to Oxford, be processed through their approaches, and then to come back to us so that we can help the countries to understand what those maps say, what the uncertainty behind those maps is, and how that information can be used into, say, a Global Fund grant. And I think that's been a really rich partnership. Increasingly, countries want to be able to do that sort of work themselves, and I think that's going to be a long process of trying to bring. We just had the MAP group down in Mozambique, and so they were working with the Mozambique team on bringing both their survey data, prevalence surveys, together with their health information data in order to have the single best maps of malaria they could get. It's going to be a while, I think, before the Mozambican program is able to do the Bayesian analysis involved, given that I don't understand it myself. But I think that is the direction that we would like to go. Make sure that those sorts of methods that are being developed in academia, out of country, are being brought as close to ground level into those planning processes as possible. Kim.
Well, that was fantastic. Thanks a lot, Justin. You were mostly referring to the eliminating countries, but I think the whole approach of stratification, targeting interventions better to subnational areas is something that's now being looked at more seriously even in the hybrid areas. So as you show, and I'll also repeat, the sort of stagnation and improvement in reducing burden of disease is really serious. And so WHO and partners are working on how to take those hybrid countries and achieve high impact in reduction. And exactly what you said, I think, is completely relevant. That we need better data, we need it at the subnational level, and we need to start looking for packages of interventions that are needed in those areas and that may have complementary effects as well. So it's great to see that Chai's got a lot of experience doing this in eliminating countries, and will be part of the effort, I think, to grow this into the high burden areas as well and look at impacts on morbidity and mortality.
Yeah. No, I was aware this morning when looking at it that I've shown a bunch of fringe transmission settings, but the places where we have the most to improve are definitely the countries that have much more malaria. And I think these methods are applicable. It's a little harder because often the surveillance systems are starting at a worse point, and sometimes it takes a while to get to where we've been able to get to quickly with a program that has higher capacity because they have less malaria they're responding to. But the methods have to be applicable. And I think that's absolutely, I've been excited to see WHO pushing the idea of how we improve data use and targeting and tailoring of tools in those sorts of settings as well. Hi.
And the question is, what's going on with Zanzibar? They have quantified the country. They know what they're doing. There's plenty of money that's been going into the malaria program there, and lots of partners that are supporting Zanzibar. But Zanzibar is not going anywhere in the elimination. It's sort of also stalled. What's going on there? Given that they are stratified and they're doing everything, but they're supposed to be doing. What are they not?
It's a great question. No, it is a good question. So I have not worked in Zanzibar myself for several years. I think our engagement was 4 or 5 years ago. But it has been a place that I've always felt really deeply about. It's a beautiful place. And it is the sort of setting where you would think that malaria elimination would be possible. And they are very close to the mainland, which continues to have a substantial amount of malaria, and thus we know there's a lot of importation. But I would agree with you that it's the sort of setting where the amount of money, the amount of effort going on doesn't seem to be sufficiently correlated with the progress that comes out the other side. I would hesitate to tell you exactly why that is, but a place I have been working much more recently is Haiti, and I think you can tell exactly the same story there. A country, again, an island in the Caribbean where technically it's been achieved the elimination of malaria from all the other islands with the same vector and similar populations, although Haiti is poorer. And yet, a substantial amount of donor funding is going in there, a substantial number of NGOs and partners are working there, and we're not yet seeing the results that we would expect to see. So I think my answer in terms of how we move forward is to go back to the epidemiology of the data, to say, where are these dollars going? What impact are we seeing? Are we testing and treating people in the endemic parts of the country? If we are not, maybe we should do that. If we have the information on who is positive and who is negative, then we should know where the transmission zones are. Are we getting the coverage that we need? Are we able to track that denominator as I showed in Namibia? Are we able to be sure that we're getting the coverages that we think? Have we looked at our vectors? So the point is to structure these problems and to start thinking through the system and to say where are the gaps and what is going wrong. And if you haven't done that sort of diagnosis of your system, then I think it's easy to keep spending money on things that aren't actually going to make the difference that we need. But I'd like to see Zanzibar be successful soon. Do you want to add anything to that, Peter? Seriously.
Well, I worked for 5 years in Zanzibar, so maybe I'm part of the blame. But one of the things in seriousness is the vector. The vector is so efficient in that part of the world. And while malaria has been brought down to very low levels in Zanzibar, most of the year, the prevalence is less than 2%, less than 1%. And 80% of the cases in Zanzibar all happen within about a 4 to 5 week period in the year. But the bottom line is we're putting all interventions that we have toward the problem, but we don't know really why that residual transmission is continuing. I think Kim might touch on it in her presentation, but many people believe it's just the enormous efficiency of the malaria vector that is there in Zanzibar. It keeps things going.
That's true, but the other thing that probably is going on there, and I would like to see the issue about multidisciplinary work that needs to happen in some of these areas is simply because sometimes people just, even in countries like Zanzibar, still don't believe that malaria and mosquitoes are connected. And the utilization of all these interventions that we have is not happening the way it should happen, and therefore we have all these sorts of problems. So anyway,
No, community education is certainly part of it. One of the things that the President's Malaria Initiative does focus attention on also. That's what I look for. But we hope in the next few years that that 1% will go down even further. But it's been, you're right, it's been a decade where it's been at that same level.
Any other questions?
Yes.
So I know we still have a long way to go on malaria, but I'm getting the sense that as we make progress, we still see lots of non-malarial causes of fever. And I'm wondering if there's any thought about ways to build in other diseases to address in some of these systems like malaria.
No, it's a great question. It's very hard to get people to participate with, say, a community health worker program if they only think of that program as providing malaria services. People typically don't see themselves as sick with malaria, they're sick, right? And if you go and you get a negative diagnosis, which will happen most of the time in the places that I've been talking about, you need to have another answer. What are we going to do? And right now, for a malaria-specific community health worker program, the answer is, well, you refer. And then you're right back in the same position where you were before. Well, okay, how do I get to a health facility? Do they have the right commodities and all the rest? So there are a lot of efforts underway to try to think about more horizontal programs that provide some of the basic services that are required, diarrheal treatment, thinking about pneumonia, antibiotics potentially. The challenge is that malaria has a cheap and easy rapid diagnostic test. It costs about 35 cents right now. And it's pretty accurate, and it's very easy to use, get a result in 15 minutes. We don't have that diagnostic for most anything else. So it's hard to say what the non-malarial causes of fever are, even though they're probably mostly non-malarial causes of fever. And that is a limiting factor, I think. Not to say you're going to want a community health worker with a bundle of 20 different tests and running your blood on all of them. But we do need to think about how we can do better than that. For years now, we've had procedures for ICCM or IMCI or these kind of basic packages of community child fever management. And I think we want to see all of these sorts of programs that I talked about fully integrated in with those, both because people are going to be more likely to use it, but also because if you're talking about malaria in Panama, you're not going to be talking about malaria in Panama for much longer, right? And if we have a system that's malaria specific, we are not going to be able to pay for that. Well, it's already hard now. It's going to be even harder when there's no more malaria observed, right? So you have to integrate these things. And I think there are definitely places where malaria continues to be the main source of morbidity and mortality, and then fine, you can have a malaria-specific program. But you have to start thinking more holistically. I was out in Mali a few weeks ago. I've told a few of this story. The malaria program is doing a pretty good job in Mali. The bed-net coverage is good. The bed-net use is good. The drugs are the right drugs. They're doing all the things that you would say a malaria program should do. Meanwhile, the primary healthcare system is broken. People don't go because they get charged a fee and they receive really bad services, and they're fully aware that they're not going to get what they need there. So you can do all you want as a vertical malaria program, but if you don't think about how do we work on the basic health infrastructure of that sort of country, how do we make sure that people have faith in their system and that they can come and receive diagnosis and treatment that is appropriate and affordable, you're not going to get very far on your malaria.
Can you comment then about the challenges of making that type of information happen? Because the funding seems to be so different.
Yeah, no, a lot of this does start with donors. As long as your donors continue to be disease-specific and offering disease-specific grants that want disease-specific metrics, life is hard for integration. But I think it is the responsibility of those of us that work in this area to try to break out of those silos. So one thing is managing up to your donors. I think governments have the ability to push back. And I think they often don't feel empowered because when somebody comes to you and says, we want to make a grant to study this specific thing, it's hard to say, well, we don't want your money. But I think if a government says, well, what we actually want to do is to use that money, but in this way, donors will sometimes listen, not always. I think groups like ours have a responsibility not to simply take contracts and do work because it's work, but to think about how can we use the money that's available to feed into systems that are more holistic and that are going to be more permanent. So I'm happy to take a malaria-specific grant if I know that there's a way that I can use that in a way that's actually appropriate for the gaps in the country. And we wouldn't go out and do a program where we're just distributing drugs ourselves because it's not going to fix the basic problems in the system, and it's not going to be a sustainable thing that the government's going to be able to keep doing. I think the donors also then bear some responsibility to eventually, hopefully, be aware of the actual problems in country. I'm not holding my breath on that one just because donors tend to have certain things that they're really interested in. It's very nice that they want to give their money, and sometimes we have to figure out how to be creative in using those resources in ways that are as efficient as possible. It's not easy, though.
I want to react to your statement about the fever diagnosis.
Please.
That we're not going to have a technology that we're going to run against 20 or 30 things.
Do you think it's coming?
We're going to have that technology very soon at very low cost, and it's going to make a big impact across the changing the objectives, to understanding fever and controlling fever rather than just malaria.
If we have the technology, it'll be great.
Well, thank you for a very
Thank you.